thanks again to IPAM to actually have this workshop. So it's my pleasure to finish the day with some thoughts about causality. And this is, we'll see how it goes. So causality is a little bit, so I'm leaving a little my comfort zone with this talk, I guess, because it's something that we only started to look at very recently, and I wouldn't claim that we know too much about causal reasoning and causal inference and causal learning in particular, but we got quite intrigued by looking at causality. Actually, I just talked to Greg about The Book of Why by Julia Pearl, which is a book I highly recommend, which is maybe the starting point. So we looked at this book with some students as well, and then we talked about whether any of this things that they are discussing about causality actually matters to us in medical image analysis. So then we started to look at some other papers, and there are some works on trying to do causal learning in computer vision, for instance. And it's quite interesting. So it was intriguing. So we started to look at this more and more, and now basically try to find links between problems we have in medical imaging and machine learning and causality. So basically where I want to start is to remind ourselves, or to all bring us on the same map of what we are trying to do most of the time when we do predictive modeling. So we have images. Let's say these images are X, and then typically we try to train a model and predict some annotation. So that would be a typical case, let's say, of supervised learning, where we are given images and some sort of annotations. It could be diagnostic labels, it could be segmentations, anything that we want to directly predict from the images. Then what we're actually interested in is to build this model, right? So we want to learn this conditional distribution given the images. What's the most likely label Y given that image? Now, if you think about how you build this model and how you train it, you already make a lot of assumptions. So maybe one of them that we also discussed during the week is that you often assume that there's sufficient training data, right? So in the supervised learning setting, you assume there's large amounts of pairs of X and Ys that you can use to build your model. The other one is that we sometimes maybe forget, but I guess it was also discussed quite a lot here, is that we assume that later on, once we have trained a model and we deploy it, let's say in clinical practice, that our test data really comes from the same data distribution. Otherwise, our model doesn't work. And we have, I guess, discussed to some extent that this is not always the case, and that causes problems. So here I'm trying to summarize what I currently see are some of the key challenges when we do predictive modeling and machine learning in general, but in particular in medical imaging, is data scarcity as the first problem, about the first assumption, assuming there's enough data. That's not always the case. And data mismatch. So trying to illustrate this here a little bit with some graphical illustrations. Data scarcity means there is some distribution of our data, P of X, of our images, and typically we only have a few labeled examples from that distribution. The other problem could be that so PTR and PTE here reflects the distributions at training and at test time. Now, training and test time could actually also mean development stage and deployment stage, right? So depending on which stage of your development you look at, it might be that you have a product and you want to deploy it in a new hospital, you want to deploy it in a new continent, on a new patient population. You might have these issues that the training data that you had was a little bit different, where you then fitted your decision boundaries compared to what you see at test time. Okay? So for instance, it could be population shift. You could actually have a shift in the population of your patient that you see where you want maybe at the hospital where you want to deploy a model. There could be other problems. There could be prevalence shift. So quite often, because in particular when you do machine learning, you work on a training data set that is well curated and maybe has been even previously collected for some other purpose. Maybe it's a repurposing of some retrospective data, and you might have prevalences in that data that are actually unrealistic or different from the prevalence, for instance, of the disease status that you see at test time. So that could happen as well. There are other issues about the selection. So for instance, sample selection. Your training data is always coming from some data collection process, right? So it could be retrospective data. As a machine learning practitioner, if, for instance, your clinicians give you a data set to train on, you sometimes might not even know how that data was exactly chosen. There might have been some inclusion, exclusion criteria that define your training set, and it might be just a small subset of the actual distribution that you would like to cover. And in that case, you might again have a problem at test time. So these are kind of trying to illustrate some of the challenges. Now, interestingly, I believe that so all of these challenges you can actually look from a causal perspective, and that's what we try to do. And thought that actually looking at through a causal lens gives us some insights about how we could tackle those solutions. So today I will not talk about too much of those solutions. Some of them may be in the area of domain shift. But generally, it's more of an attempt to convince you that causal reasoning would allow us to shed some new light on those challenges. So what is a causal perspective? For those people who are not so familiar with causal modeling, just a very short background, as simple as that. There is maybe a cause and there's an effect. And this is a causal diagram, right? So this is a structured causal diagram telling us that there's a cause A, and that leads to an effect B. Now, this model that we have here, this causal diagram, is actually describing a mechanism. Okay? So the mechanism is exactly what's happening when the cause A appears and how it turns into the effect. Right? So that's called the mechanism. And there's an interesting principle, if you think about causal reasoning, which is stating that there is an independence of the cause and the mechanism. So I'm not going into the details of this, but we should remember this one because it will come back in a second. So remember that the idea here is that the cause and the mechanism are independent. What does that mean? So let's think about a setting, maybe more in the medical application, where there are some symptoms, A, and those symptoms are maybe presented by the patient to the doctor, and the doctor suggests a diagnostic test, right? And this mapping from symptoms to the diagnostic test is often described in guidelines. So doctors are not making these things up and say, oh, you have this cough, you have this fever, you have these things. Let's try this diagnostic test or this imaging, for instance. Typically, they actually follow guidelines, right? Often it's written down. These type of symptoms mean you should do these type of tests. Now, going back to the independence of causal mechanisms, actually it means that, so here maybe this illustrates a little bit why this might be true, is that if you think about the distribution of all symptoms, they are really independent of these guidelines, right? So the guidelines say, if you see certain symptoms, you do this type of test, but that's really independent of the general distribution of our symptoms. So that's kind of the idea. So now going back to imaging, so what is the relationship actually between images and annotations? And that's, I think, for the first time where like it kind of struck us that maybe there's something interesting to do with causality here. Because typically I don't think we talk about the relationship between X and Y. We might think that the image X is causing the label Y. So that would be something that we call a causal relationship between the image and the annotation. And remember, what we are trying to predict is this conditional distribution. So we are trying to predict the effect from the cause. Okay? Now, this might be the opposite. It might actually be that the annotation causes the image. So the label causes the image. So this is called an anti-causal relationship between the two. And what we're actually trying to do in this case is then we predict the cause from the effect. Because this guy doesn't change, right? We're always interested in, given the image, what is the probability of a certain label, a predictive task. But now the question is, does it matter? Does it matter whether it's a causal or an anti-causal relationship? Before we discuss whether it matters, I want to convince you that these two cases actually exist in practice. So let's look at some examples. So this is skin lesion classification, for example. So our images would be maybe dermoscopic images of these little molds there. And let's say our labels that we use to train, let's say, skin lesion classifier are derived from biopsy results. So in this case, what would you say is the causal relationship between X and Y? Any thoughts? Any suggestions? What is causing what? Is the diagnosis causing the image, or is the image causing the diagnosis? So I would argue that it's this direction, right? Because it's not really the image that causes the diagnosis. The diagnostic label was derived with biopsy, a non-imaging test. Or maybe an imaging test, but a different imaging. Right? Maybe they cut out a little piece, do histopathology. So that the presence of cancer or non-cancer here is really the cause of the image. Right? The image will change whether it's cancer or it's non-cancer. So I would argue in this example we have an anti-causal relationship. So we're trying to predict the cause from the effect. So this is an example where we then draw a causal diagram for an application of skin lesion classification, basically just to illustrate that causal diagrams can be really useful to actually communicate what your assumptions are. So remember, the image is what we are given. We want to predict the disease status, right? That's the task. But then you might actually, in your data set, have some knowledge about how you got your labels. So maybe all the training data that you got was coming from a screening program, and biopsy-derived diagnosis you typically don't get for everyone. You only get it when there was a suspicion in the first place. Okay? So this is an attempt to show you that causal diagrams can communicate assumptions about our data. And if this is true, let's say our training data set for a skin lesion classifier was collected in this way, where images had to be suspicious in the first place, and then you were, and this is defining whether they are selected, basically being in the training set or not. That means you have a bias in your training data set, right? Because you wouldn't actually see normal moles because you wouldn't do biopsy on them in the first place if they didn't look suspicious. So it's just illustrating that you can communicate a lot with these causal diagrams. So here's another example, brain tumor segmentation. So let's say we have a structural brain MRI. We have seen a few examples of that earlier. Let's say our manually drawn contour is the label Y that we want to predict. What's the causal relationship between the two? I would argue, in this case, it's causal. So that you're given an image, the radiologist sits down, or any expert, and draws the contour on the image. Right? So I would argue that this manually drawn contour is an effect of the image. So in this case, we're trying to predict the effect from the cause. And here's just another causal diagram that tries to communicate maybe a setting where, so this is made up, right? But a setting where, let's say, we have the image, we want to predict the segmentation. The disease is actually causing the image, right? But we don't know anything about that. We don't have a direct label. What we're trying to do is image segmentation here. But what we can also encode is, for instance, a shift that depends on whether we are in the train or test domain. So we could say that either the disease distribution might change whether we are in train or test. So this is illustrated with this diagram, with this arrow, or it could also change the image. What does it mean if the train and test domain have an effect on the image? It means that maybe they use a different scanner. Okay? So you can encode this information again in a causal diagram. So this is another example where I'm trying to show that it's not always as easy. So let's say we have images of chest X-ray and we have radiology reports. And we want to actually distill the labels from the report. Let's say the diagnosis. It could be that it's somewhere written in the text what the diagnosis is and so on. So the question is now, what is the causal relationship between the images and the diagnosis extracted from a report? Any suggestions?
Why is cause?
You say Y causes X?
How about both?
Actually, I would argue we don't know. From just the information I have given you, it's hard to say. So it could be, and now this might not be clinically correct, but it could be that the radiologist has read this, maybe looked at some other stuff, and written a diagnosis here, which was mostly driven by the image. But I guess normally there might be some other information. Maybe there was even another lab test being done, and the image is actually just it's just a visual confirmation of a blood test or something. And the actual diagnosis is derived from a blood test. So if you don't have the necessary meta-information, you might actually not be able to establish the causal relationship. And this is an argument for saying that we need meta-information. So it can be actually difficult to just establish causal relationships from the information you have. So we try to come up with a list of things that people should report, ideally, or if you do machine learning with some clinical partner, these might be questions you want to ask your clinical collaborator, or you really want to try to get answers to these questions, because it might help you in establishing the causal relationship between images and annotations. So the question is now, does it matter? So we have hopefully seen that there are examples where it's causal, there are examples where it's anti-causal. Now let's look first at data scarcity, one of the challenges I mentioned earlier. Now interestingly, and I think this was the most striking one so far that we found in the literature, where we said, actually we believe that causal relationships might affect us in what we're doing. So in data scarcity, the idea is that labeled data is scarce, unlabeled data is abundant, right? So there's often this notion of it's easy to get more scans, but annotations is difficult. And there's this idea of doing semi-supervised learning, which basically says, can we leverage unlabeled data to get better predictors? So I guess the idea here is really, so you have only a few samples from your distribution, but you have lots of images that are unlabeled, and maybe those images can help you to get better decision boundaries. And people who are familiar with semi-supervised learning might know that there are assumptions like the cluster assumption. So you assume that, for instance, if you look at the data manifold or the data distribution, that images close by should usually have the same label, as an example. The other assumption is that decision boundaries should typically lie in low density areas, right, between clusters. So if you wanted to separate the blue and the red class here, you might think that a decision boundary lays somewhere here between those two clusters, right? And that the decision boundary isn't like this, you might infer from looking at some unlabeled data sets. So that's kind of the intuition behind semi-supervised learning. Now the question is, are these good assumptions, and does it matter depending on the causal relationship? Now, so think again, so the joint distribution of your x and y is just this, and your unlabeled data gives you information about p of x. So remember, we have these two cases, causal and anti-causal. That's the thing that we want to learn, right? A conditional distribution, given the image, what is the label? And remember that we have, this is basically describing the mechanism. P of x is the cause, right, if we're in the causal setting. And remember, we have this principle of independence of causal mechanism. So that is basically coming from this work by Bernhard Schulkopf, where they argue that semi-supervised learning might actually be futile in causal relationships. And going back to our example of image segmentation, we not concluded, but thought that this should actually mean that semi-supervised learning shouldn't work in image segmentation, which is kind of interesting because there's a lot of work on that. There are lots of papers, lots of approaches suggesting to do semi-supervised learning in the setting of image segmentation, including ourselves. So we have done work on that as well. Now, it's interesting when you then come across a statement like this. So this made us think. So the other thing is, in data scarcity, how people try to tackle data scarcity is data augmentation. And I think, again, causal reasoning can at least explain some empirical observations that data augmentation helps. Interestingly, it does help in both settings, causal and anti-causal. And the reason why it works might be that actually what you try to do with data augmentation is you just generate additional pairs, hopefully with some realistic perturbations. So you could think of an image that you perturb by, for instance, rotating, scaling, and so on. You basically try to augment your data set. And more interestingly, there is some research in this, for instance, from Ender's group, very nice, on trying to learn augmentation. So I think this is really an interesting research direction, while semi-supervised learning in image segmentation might not. But we don't know exactly. But that is the reason why data augmentation works so well, because you basically try to generate additional pairs of the joint distribution, and that affects both the anti-causal and the causal setting. Okay, so this is on data scarcity. Any questions on that? No?
Could you elaborate once again why SSL is futile for image segmentation?
Yes. So this is coming from causal reasoning. So in causal reasoning, it states, this is a major principle in causality, saying that the cause is independent of the mechanism, right? And remember that the mechanism is this. So going from the image to the label is the mechanism in the causal case, right? So if we're in a causal setting, this is the mechanism, going from X to Y. Now, this principle just says that a distribution over X is uninformative for this conditional distribution. This is just the principle, right? If this is true, then it shouldn't work in image segmentation, because we just established that segmentation is a causal relationship. Someone draw a contour on an image. If you change the image, the contour will change, right? So the image is the cause, and the contour is the effect. Yeah?
Maybe I might be lost a little bit, but in this picture, you mentioned that the decision boundary should be somewhere in between the group, right? But however, in this kind of learning and semi-supervised learning setups, depending on how you learn, sometimes that group cluster in this way or sometimes differently, right? So you don't know which, it's like linked together.
Yes.
So you don't know the separation of priority, right?
Yeah. So I mean, this is a toy example of illustrating why people believe that the cluster assumption and the low density separation makes sense, right? If someone wants to convince you, I use cluster assumption and low density separation, they draw two half moons, right? And say some of them are labeled, and this is why you think it makes sense to put the decision boundary. How it is in reality is very difficult to see, right? First of all, this is typically very high dimensional. So what does it mean to be low density in high dimensions, where anyhow you might have 1,000 examples in a very high dimensional space? Wherever you are, it's low density, right? So I mean, it's just questioning some of those assumptions, right? But I think that is actually what causality is about. It's all about making assumptions, questioning assumptions, and so on. So I'm not saying this is true. This is why we put this may. But if you go through the theory, this is what comes out, right? So I think it's just interesting to think about it. So this will be the nature of the talk. Okay, so data augmentation we discussed. Any questions on that? Mm-hmm. Yeah.
I mean, how would this be compared to a much more traditional approach like kernel density estimate? Because there it's like the standard way of trying to just see where the densities are.
But that is density estimation, right?
But for when you're augmenting the data.
Yeah, for augmenting the data. I mean, for me, data augmentation is just a way of regularizing whatever model you fit, because you basically take real examples and you wiggle them around, so you create like locally neighboring examples that look somewhat similar. I think the reason data augmentation mostly works is because if we use things like deep learning, it's very data hungry, and adding this like additional perturbed examples just helps. It might add a bit of robustness to certain things. It might add some invariances or equivariances, but yeah. I mean, the question is, how do you generate them, right? So I guess so far there's a lot of work on basically just have like policies or strategies for randomly generating transformations. They can be in appearance space, they can be spatial transformations. I think this is actually quite interesting, because that's where you can really leverage unlabeled data, where you look at P of X, the distribution of your data points, and then try to learn what are realistic perturbations. Yeah.
Somehow it's a subtracting. In order to make a good augmentation, you know there's some decision boundary.
Mm-hmm.
Decision boundary, but that
Yeah, and I'm not sure for the data augmentation you do need to know anything about the decision boundary. If you already know the decision boundary, then yeah. I mean, there are ideas where you, for instance, try to augment towards the decision boundary, right? Yeah. Where you basically say, I mean, there are these approaches, what is it called, mix-up or something. So you take labeled data sets, positive, negative, and you produce something in between, right? Where you actually blend between data points. And the idea is that those two data points move closer to the decision boundary. So now your decision boundary needs to, I mean, if you have just positives and negatives, right? And then you say, where's the decision boundary here? I mean, it could be this, it could be this, it could be this, depending on what criteria you have. And now if you start moving, trying to augment in this direction, probably this one is more likely, right? It's maybe fulfilling some sort of max margin kind of criteria also. I don't know. It's a bit hand-wavy. Okay, so dataset shift. So I think this is maybe even the bigger problem than data scarcity. You might argue otherwise, but dataset shift is quite common, and we see it all the time. I think Tom mentioned it, some other people mentioned, how do we deal with this currently? Sometimes we try to do things like domain adaptation. I will talk about this a little bit, but the idea is, again, if we use causal reasoning and causal diagrams, we can formalize what type of shifts there are. Because I don't think it's that useful to just say, oh, there might be shifts. There might be dataset shift between my training and my test. So what we're trying to do is here to formalize what type of shifts do actually occur. And again, we can use causal diagrams. So if we go through this, for instance, in the causal setting, X is causing Y, then we could introduce this Z variable, which is somewhat the unobserved true anatomy that we never see, right? It's the actual patient, the physics, the physical reality. And that might change, right, depending on where you are. Different hospital, different continent, different age populations, whatever. So that means if this changes, so if your domain is basically just affecting the true unobserved anatomy, obviously this affects the images you see, and this is what we would call population shift, right? And it only affects this marginal distribution over Z. An acquisition shift means the patient population doesn't change, but your image hardware might change, your image acquisition might change. So your domain has an effect on what noisy measurements you get of the true anatomy, and this is what we call acquisition shift. Now this affects this conditional distribution here. And depending on which distribution is affected, you might come up with different solutions to tackle this. So interestingly, for instance, population shift, theoretically, is not a big problem, because this guy, what you're at the end interested in, right, given the image predicting the Y, is the mechanism which is independent of this. So the mechanism will still hold, right? If you learn this mechanism from data, it shouldn't really matter whether this changes, right? The only problem is that, let's say, again, going back to this illustration where you have data scarcity and you have only a small portion of the true distribution, then obviously your predictor might be biased, right? Let's say these are all the young people and you never see old people, then it might still fail. But yeah, it's interesting to try to formalize a little bit these data set shifts. And so what we are trying to do here is to basically come up with names that are clinically more meaningful than machine learning terms like covariate shift and so on. So they kind of have a matching name in the machine learning literature. So there are some very interesting ones. For instance, manifestation shift basically means that the domain, so let's say again, continent, decides on the true unobserved anatomy, but this is affected by the disease. So this basically means that the disease has different effects on the true anatomy, which is kind of a weird one. And it's very, very difficult from a machine learning perspective to do anything about this. Same as annotation shift. So this might actually happen in practice quite often. Let's say you get data from different sites and they use slightly different protocols for doing annotations. Let's say one hospital is coming up with a procedure of annotating or grading patients. Let's say you have different grading schemes. Then it's very difficult to actually compensate that. So you might have to re-annotate data to make use of data that comes from different sites if there's a mismatch between annotation protocols. So yeah, so you can derive some differences from there. It's important to look at which distribution is affected and so on. And then once you know this, once you establish this, then you can try to look up whether there is a solution in the machine learning literature to do anything of that. I just want to convince you with a little experiment. The acquisition shift is very present, and it's actually sometimes surprisingly subtle, I guess. So this was a little experiment we did run on 3 T1 weighted brain MRIs, taken from 2 studies, CAMCAN and UK Biobank. So what we tried to do here is kind of simulate an ideal multi-site neuroimaging study. I say ideal because typically in multi-site studies you don't have the luxury of generating data set, for instance, that is age and sex matched. Right? But what we tried to do is basically to remove any confounders other than imaging, right? Other than acquisition, which is not entirely true. I mean, these are healthy subjects, but just matching age and sex, there might be still other differences, of course. But also from the acquisition point of view, and I'm not an MR physicist, but at least to me, it looks reasonably similar. So it's both like Siemens scanners, 3T, reasonably similar imaging protocols. So interestingly, if you look at the images, which I will show in a second, it's not obvious what the differences are. So we took this data from 2 different sites, and then we did pre-processing as maybe a neuroimaging study would do. So we tried to come up like with a reasonable state-of-the-art pipeline. So we did some reorientation, skull stripping, bias field correction, registration to atlas space, intensity normalization. Then we also run some neuroimaging tools to extract tissue maps. So these are some images, so intensity histograms between the 2 sites. So this is CAMCAN data, this is UK Biobank data. These are always like same sex, same age in the column. And I would argue that like just looking at the images, there are no obvious differences. I think the trained radiologist might see differences. I believe UK Biobank has a slightly higher contrast, but it's not immediately obvious that there are big differences between the 2. More interestingly, if you look at extracted tissue maps, for instance, with FSL or SPM, so these are all now nonlinear registered to MNI space, so there's no difference, or there shouldn't be much difference in terms of the anatomical correspondence between images. So a pixel or a voxel in an image should kind of match to the same anatomy across images, across subjects. Again, there are no obvious differences. So we did this little experiment where we first did, so we trained a classifier and wanted to see if the classifier can tell us where the data is coming from. And not too surprisingly, it can, with very high accuracy. However, what was a little bit surprising to us is that, for instance, if you look at rigidly aligned scans and affinely aligned scans, right? So here you add scaling, and anisotropic scaling, that the accuracy of the classifier increases with the degrees of freedom of your registration method. So this was on the raw, not on the raw, on the T1 weighted MRI. After all the pre-processing, you can do this on the gray matter maps, on the probability maps of gray matter. So those shouldn't have like MR intensities anymore. It's just a probability map. On the probability map of gray matter, you can still tell if they are rigidly aligned with 80% accuracy if it comes from CAMCAN or UK Biobank. If you look at the ones that are non-linearly registered to MNI space, you can tell it with 96% accuracy. So it means that those images, even after lots of pre-processing and tissue extraction, contain information about where they are coming from. That was quite interesting. In particular, this jump here from rigid to nonlinear. So I believe this is coming from interpolation effects. So if there's a different SNR, for instance, between the images, or something that is being amplified when you scale the image and resample it, that seems to be encoding site differences. We then did a bit of a toy task. So we wanted to do a binary classification between the images, and the only information we had was age and sex. So here we tried a sex classifier to tell us for a brain scan whether it's male or female. And interestingly, so the numbers are as follows. If you take multi-site data and it's age and sex matched, you get something around 82%. If you do single site, you get something like the same, right? So what it tells us is if we have perfectly age and sex matched data, we don't have a problem, right? We can mix the data, and there's no problem of pooling data from two sides. You get similar accuracies in this task. Now, obviously, if you have like a complete mix, a complete separation of all the females come from one side, all the males come from the other side, you go back to site classification. That's not surprising. This is maybe interesting because it could actually happen quite often that, let's say, you have data coming from two different sides and you have a bit of a mismatch between, let's say, healthy controls and patients, right? In this case, males and females. But you basically then overestimate your accuracy by getting better results than you should, because the classifier can also rely on site features. Now, the really interesting one is comes on the next slide, is when you do train on one side and test on the other. Now, in this case, there's no problem. We still reach 80%. Right? So that is what we get on single side. We get if we train on one side, test on the other. The reason why we get this is because we look at rigidly aligned scans. And the most discriminative feature for doing sex classification is overall brain volume, right? And that is preserved when you look at rigidly aligned scans. Now, what happens if we look at affine scans? So we remove the most discriminative feature of brain size or overall brain volume. Actually, it's still possible to do sex classification, so it's not just the volume, there are other differences. You can still get 80%, roughly. You get 80% if you do single site, you get 80% if you do multi-site age and sex matched, and you drop dramatically when you do single site training and the other testing. So it means when you suddenly don't have this very discriminative feature to do your task, but you have to rely on maybe more texture, intensity, or whatever it is, it doesn't generalize. So that was, I guess, the interesting take home from that. Now, what's the time? So I want to talk a little bit about how can we tackle that. So this is an issue of domain adaptation in the context of acquisition shift, right? So there's some problem between the data is mismatching just because of acquisition protocol. So one way of doing this, so this was work by one of my PhD students, Kostas, who looked at what we called unsupervised domain adaptation. So we had a neural network that was doing a task, in this case, lesion segmentation. So this is our illustration of our segmentation method, which is not a UNet, by the way. It's called DeepMedic. It's slightly different. If you're interested, I can tell you what the differences are and why we are fans of this compared to UNets. But that's not so important. It works with UNets as well. But the idea is basically in order to do the domain adaptation, so have a network that is trained on data from one side but still works on the other side, is that if you have data from the other side, but without labels, what you can do is you can include a so-called domain discriminator here, and it can look at different stages of your neural network, so basically at different layers of your feature extraction, and tries to counter that those features look at site-specific information. So this is an adversarial training, so this discriminator is trained in a way that it says, whatever feature you extract to do your downstream task, let's say image segmentation, those features should be invariant to where the data is coming from. So the way you train this is basically you show it data from your, what we call the source domain, where you have labels for segmentation, and at the same time you show it unlabeled data sets from your target domain, and then you say you minimize your task loss, but you also minimize the ability of a discriminator to say where the data is coming from. So that's the adversarial part of it. And that kind of works to some degree. So it does lead to domain invariant features. I'll show you in a second some numbers on that. And you don't need labels for the test domain. However, this means you need to retrain for every new domain where you want to deploy your method. So that's a big disadvantage. So here are some visual results. So the actual task that we had is kind of related to something that Tom was mentioning earlier. So we had lesions to segment. So this is traumatic brain injury lesions, and they do this multi-sequence MRI. And we had a data set where we started to train, where we had manual segmentations, which we call our source domain, where they used this sequence, which is called gradient echo, which gives very good features about microbleeds and general bleeds in the brain, which are important things to detect when it comes to traumatic brain injury. However, and this was older data, retrospective data. But then they wanted us to actually use that segmenter on the latest data, and the latest protocol says they got rid of the gradient echo scan and replaced it by something called susceptibility weighted imaging, SWI, which from a clinical perspective they said is equivalent. So they said, oh, this is giving us better image quality, but it's basically used for the same task, detect microbleeds. But from a machine learning perspective, it's very different data. So you have a massive domain shift. And that is happening when you test your trained algorithm on this data using gradient echo. You replace this sequence for your test images, and that's what your algorithm does. This is the manual reference. Right? Now what you can do is you can say, okay, if this is different, maybe we can leave it out. Right? Maybe we just focus on the sequences that are in common between the two, and you get something much better. However, you're missing now exactly those small microbleeds that you're interested in because you don't have a sequence that shows them. And we can show that with the domain adaptation that I showed you earlier, like in this illustration. You can actually go back to a segmenter that is only trained on source labeled data, but that basically says train something that is domain invariant, and it can still detect the microbleeds using a new protocol. So this you can see here. So this was quite nice, and this is just another example. All right, so the one big problem with these domain adaptation techniques, and I think in general with adversarial training, so people who have used it, is that it's not easy to train. So adversarial losses are a little bit unstable, and you basically need to babysit a little bit the training procedure. Here I'm just showing you in different settings, so we try to see where in the neural network we should basically try to add that loss, right? Where should we say try to be domain invariant at the end, just before you make the classification, or somewhere in the middle. So we tried all these different combinations. But generally what you see how this domain discriminator works is that initially it's very effective in telling you where the data is coming from. And then hopefully over the training process, it basically loses its ability. So ideally you want this to go down to 0.5, right? And at the same time, that is what you look at in terms of segmentation accuracy. So you need to be very brave when you reach this and hope that at some point it will go up. So don't give up when you see this. Just wait a little bit, and then hopefully it reaches some good segmentation accuracy. So these were the numbers in terms of dice scores, typically things that you compute. Just to show you basically what happens. So if you just train naively and then test on the new side, you get like complete failure. If you remove this sequence that is for microbleeds, you get a dice score, but not as good. So we can almost reach a dice score that is as good as if you would actually train on the target domain. So that is the take home, I think, here. So all these actually need labels on your target domain, right? While this doesn't. All right. Domain generalization. When did I start? 20 past.
Principally, you have 6 minutes.
Okay. Let's do this one quick. So domain generalization is just a way to say there are other ways of doing this. So domain adaptation, as I said, the big problem is you need to retrain on the new target domain every time you wanted to go to a new hospital, right? So in domain generalization, we try to do something different. We say, what about we could generalize our technique already at training stage to domains that we have never seen? And the idea is that you use, so this is not our idea, this is what people suggested is, why don't you simulate domain shift already during training? Now the assumption here is that you have at least 2 domains at training time. Okay? They're always assumptions. So let's say we have data from 2 domains that is labeled. Can we generalize to a 3rd, 4th, and so on domain without ever having seen it? It turns out that there aren't many data sets for medical imaging to do this, but in machine learning and computer vision there are some benchmarks. So they like these benchmarks, So there's a data set called PAX benchmark, which basically stands for photo, art, cartoon, and sketch. These are the domains that they look at. These have joint categories of dog, elephant, giraffe, guitar, and so on. So it's an image classification problem. It's an interesting one because I think the domain shift is severe. If you think about you want to train on real photographs, but then you want to make a classification on a sketch, for instance. So it's an interesting domain shift problem. I think it's more than an acquisition shift problem, actually. There are also really domain shift problems. So there's this VLCS data set where they basically have just photographs with joint categories, and they just come from different data collections, right? So I think this stands for Pascal, VOG, this challenge, Label Me, Caltech, and Sun or something. So this is all within photos, and this is going in really crazy domains, different domains. So the way we try to tackle this is to come up with a domain generalization approach. And it's based on an episodic training and 2 new loss functions. But I think I will skip the details. But just to tell you how it in general works is you basically, instead of having your one network that does your task of image classification, you separate this, and we have seen this a couple of times in other talks. You separate it into a feature extraction stage and a task network, right? And they have this common interface of a latent representation. And you can do things on this one, and you can do things on this one. And then you can get to domain generalization. Episodic training is really simple. It basically just means that at training time, that's why you need at least 2 domains. You have something called the meta-train and the meta-test domain, and you basically do certain gradient updates on your train, and then you check certain loss functions on your meta-test. Right? And these loss functions, I will just illustrate what they try to do. One of them is called global class alignment. So your feature extractor gets data from 2 domains. So these are the 2 different domains, let's say photo and cartoon. What you're doing is, some equations here, but basically what you're doing is you compute the mean representation for a class, right? So this is just this averaging over the representations that come out, so the feature vectors that come out of this feature extraction stage. And then you pass them through your task network, and you get some sort of a probability of that feature vector. So each column here is basically telling you how likely it is that this average feature would be, how it would be classified. And what you're trying to do is to say that you want to align these 2 probability matrices, these confusion matrices, if you want. So this loss is basically saying, independent from which domain you come, you want to do the same confusion on the corresponding classes. So the idea is that you preserve interclass relationships. So think that misclassifying a dog from a cat is maybe more likely than misclassifying a dog from a house, right? And you say this is true across domains. That's kind of the assumption here. There's another loss that says local sample clustering. So again, going back to this clustering idea, where we say feature representations of one class coming from different domains should go together. So you can use a contrastive loss here, or you can use a triplet loss that basically says within a class you want to stay close, across domains you want to push apart, right? So that's basically done with another network that you add that tries to learn this metric. It's a metric learning approach that you run on the side. I skipped this, so we got the best results here on these benchmarks with lots of other methods reported in the literature. The interesting one is this. This is our baseline, where we basically just use a deep network where we ignore, so where we basically just train on the 3 domains, and we just ignore that they are different domains, and then see how well it works on the holdout. What I did find interesting is that it actually already gives reasonable results, even if these domains are quite different. Okay, so we did a few studies on that. We did try it on medical, but it turns out that actually on these brain scans that come from different sites, the domain shift is much, much more subtle and less extreme than in these benchmarks. So it's very hard to actually beat this baseline. Right, so training a deep net on 3 different sites works actually quite well to generalize to the 4th side. But we still got a little bit of an improvement. So back to causality. I didn't talk about sample selection, but this is just saying again, causal diagrams help you to communicate. So for instance, if your sample selection is completely random, like in a randomized trial, that would be seen like this. If it's image dependent, so you could have a quality control measure of telling you whether include a data set or not, that would be image dependent. You might do it based on the diagnostic label. You might do it based on both. And it's important to know about these things because you get different biases. So this is just saying that if you draw your causal diagram, you can communicate to others what your assumptions are. So we believe causality matters. We did do this in the context of looking at recent developments regarding guidelines and reporting, and there's a lot more discussion and debate in the radiology community about how all these like new AI studies on doing breast cancer detection and all kinds of different problems should be seen and reported and what the conclusions are. So we believe that actually causality would help to complement some of those requests. So there are currently requests about how you, like, what type of information you have to provide when you do an AI study in predictive analytics and medicine, for instance. And we think that actually doing this might help as well. So these are the recommendations we have. That you should gather the meta information. It's important to report what are the assumptions, what are the things that you do to collect your data, to annotate your data. You should try to establish your causal relationship. You should try to identify any mismatches. You should talk about what you expect, what might happen after deployment. And you can talk about how biased your data set is and so on. And in order to help people with like drawing the full diagram, we came up with a scaffold which tries to almost like capture the most important things that might happen when you do predictive analytics in medical imaging. So you can use that, refine that, go into more detail or less detail in certain areas. So I think I will finish here, say there's a bit more of causality in this report that we put on archive. So these are the two guys who looked through all the causality literature to find the interesting cases. And I just conclude with this, that I do believe that causal reasoning, and again, I have to emphasize that we are not experts in this, so this is like the first time we look at this. But we do believe it's a useful tool to communicate, especially when it comes to communicating what the data generating process is. So anyone working on representation learning, disentanglement, generative models, I think should be interested in what is the underlying causal relationship of the data, because that might lead to what's called causal representation learning. You can read more about this in Bernhard Schulkopf's recent, I guess it's a perspective or thoughts about how causality matters in machine learning. That's where I stop. I go to my last slide. I had more, but I don't have time. So I just finish here. Thank you.